Director of the UCA Medical Center, Professor of Neurology, and Director of the Neurovascular Imaging Research Center. Professor Libeskind, please give us your lecture. Thank you very much.
Oh, thank you very much. Just give me a second to pull up my slides. It's a great pleasure to be here, a great honor. Can you hear me okay? And do you see this? I apologize if they're in small size. Do you see do you see the slides? Yep. Okay. Sorry about that. So thank you, Professor Ra. Thank you, Professor Ramani. It's a great pleasure to be here and share with you how endovascular therapy is changing now at this juncture. I apologize. I wish I could be there in person with you as had planned. So this is a virtual talk, but to speak about some very real aspects of stroke care. Ischemic stroke, as you know, is complex, and as Professor Raj just showed you, has quite dynamic pathophysiology. Perhaps it's been oversimplified about what we did for many years in terms of using non-contrast CT scan, followed by solely by IVTPA. This new normal that we're in during this year of a pandemic has really given us an opportunity to revisit what we did on routine. Many things that we did in the past, we did simply because we did out of habit, rather than truly assessing the need for specific types of imaging. I'm going to be speaking to you about imaging selection for thrombectomy, new platforms for selection for thrombectomy, different ways of going about this. But I would put forth the controversial question that I've been asked before, which is, can we not just bypass advanced imaging? Is it possible to bypass the CT scanner? This is something that I think that we will see in coming years as well for endovascular therapy. But when we think about the impact, we have to think about, not being perfect in terms of prediction. We have really focused our efforts to try and perfect what we can do in terms of predicting who will do well and who will not do well with or without therapy. But what we are really focused on is making sure we give the best possibility of outcomes for the best outcomes in the largest number of stroke patients that we see. We need to really maximize what we can do in terms of therapies, our tools and our therapeutic options for this very devastating disorder. The focus until now has been on what we can do at the most basic level in terms of extreme simplicity and getting the simplest amount of information in the shortest amount of time possible. But we know that we can see a lot more. We can do a lot more with multimodal imaging. And this is true not in all centers, but in many centers now. And as Professor Ross showed, as well as in terms of we don't have to be there directly. We can do this through AI on our telephones. Is it multimodal imaging truly mandatory? Do we need this before making a decision? And this is a quite complex topic because it depends on a lot of factors. So what we do at the most basic level is we tend to use non-contrast CT to rule out hemorrhage. Now, I would put forth that for many years we knew this. Most of the time, clinically, we know or suspect when the deficit is due to hemorrhage or ischemia. The other thing to consider is that IVTPA, in animal models at least, has not been shown to worsen hemorrhages. That is not been an issue. So this big concern about treating with TPA perhaps has been overblown. IVTPA does not require a confirmed diagnosis of ischemic stroke. We don't need to see ischemia on a non-contrast CT. But despite this, paradoxically, in the majority of acute ischemic stroke patients that we see, the non-contrast CT findings are ignored. We gloss over them because they're difficult to see. Sometimes people have old lesions with superimposed acute lesions that makes it much more difficult, or contralateral or bilateral lesions, very difficult scans. And we kind of shrug our shoulders and we're not sure what to make of it. But for endovascular therapy, this situation is very different than with IVTPA. For endovascular therapy, we need the presence of an arterial occlusion, and specifically a more proximal arterial occlusion in the anterior circulation, at least until now. So the question is, is a minimal aspects or a maximal core size likely to determine our use of endovascular therapy? And this is something that is being trialed in many studies now, several different studies being done around the world. The large core studies or the low aspect studies that we refer to, and we will have an answer within 2 years. So within 2 years, we'll know how low can you go in an aspect score, how severe is that lesion that you shouldn't be taking those patients to the endovascular therapy. At that point, though, it'll pose a lot of questions because at that point, we're going to have to determine whether it's even worthwhile looking at the core size. And obviously, this depends on what the studies show, what the results look like. But it gets to this better question of what are we after when we image an acute ischemic stroke patient? Are we trying to confirm a positive diagnosis of acute ischemia on a diffusion-weighted study? Or are we simply trying to target the presence of a complete occlusion of an artery? So it all depends. It depends on what you're looking for. And this question comes up all the time. Almost every day amongst colleagues and trainees, we share this question of, would you get certain imaging in this situation? What will it take for you to make that decision? And as I said earlier today to my trainees, there are no two stroke cases that are alike. Each one presents somewhat differently. The features are a little bit different. And then the imaging is one slightly different than the next. So it's not so absolute in terms of absolutely treating one group of patients versus the next. And one can argue that it's not just all about this go, no-go decision. That there's a lot more to be considered after that in terms of what we do once we're in the angiography suite. So it raises the point and question that many have raised, and many of our colleagues have suggested, that perhaps we shouldn't be looking at inclusion criteria. We shouldn't be looking to select patients. Who should we deselect? In which patients is it prohibitive to go to endovascular therapy for acute ischemic stroke? I would argue that that imaging selection for thrombectomy is obsolete. The go, no-go approach is old school. This is part of old-fashioned habits. It's not just about that. Now, this doesn't mean don't image. I'm very much in favor of imaging, but it means use the imaging to answer the questions that are most salient or most direct towards your decisions. So imaging provides a tremendous amount of information. Multimodal CT with non-contrast CT with CT perfusion as well as CT angiography and multiple sequences on MRI tells us a tremendous amount about what's going on in terms of the brain as well as the vessels that are feeding the brain. The guidelines about imaging have been somewhat misinterpreted recently. In the last couple of years, the American Heart, American Stroke Association guidelines made some statements about the use of imaging, and these were partially misinterpreted. What they perhaps intended to state was you should use what you need and not image without any thought. You shouldn't just simply go forward through a protocol without thinking about what you're going to do with that information. So if you're not going to do anything with that imaging information, then perhaps you shouldn't be imaging any further. But it's all about the decision making. It's all about how will you use that information to take that patient to the next step, which may include endovascular therapy. Multimodal CT, as I mentioned, is shown here. Non-contrast CT together with CTA as well as CT perfusion. There are many variations, as you know, of single-phase CTA versus multi-phase CTA, as well as different ways to approach CT perfusion. The equivalent exists here on MRI as well. We have multimodal MRI with MRI parenchymal sequences, which typically include the diffusion, the flare, the gradient echo, MRA, and perfusion parameter maps. But this is all about diagnostic and therapeutic confidence. It's all about the probability that recanalization is better than persistent occlusion. What is it going to take for us to make those decisions to go forward? Excuse me. It's about the sequential decision making. And what I would argue is that the minimal requirement is an underlying arterial occlusion. We need to know that that neurological function, that dysfunction, is associated with that lesion. But from a therapeutic standpoint, one can argue, what alternatives are there? If you're not thinking about anything else, if you don't have a good therapy as an alternative therapy, then perhaps it's not a relevant decision that we should be treating these patients anyway. And there are no guarantees, of course, if you do go forward. AI was mentioned a moment ago by Professor Ra. There is a list that's evolving in terms of FDA-approved AI approaches. This list is going to grow by the week, and you're going to see one of many different types of approaches. The most important thing about the AI, is, at least that I'll say as an imaging aficionado within neurology, is it will never replace our job as a decision maker. So these are notification schemes that are helpful in terms of improving workflow, but looking at the images and confirming that together in the clinical context is always going to be important. But this is about the real world imaging of acute ischemic stroke, not about trials. I think we have to think about, what happens in the real world. In the real world, there's a variety of imaging approaches that are used. There's extensive information, as I mentioned, on imaging. And imaging, and even AI, does not select patients for thrombectomy. Machine learning can optimize our imaging results. We have to be careful in terms of what we define as the ground truth of core and penumbra definitions. And not just take everything as proven. Imaging definitions of core and penumbra have been based on probabilistic models of angiographic success. They're also not based on the presence of intracranial stenosis or other time windows. All these factors are very, very important. And then finally, angiography itself, conventional angiography is a form of imaging. It provides diagnostic information and obviously is used from a therapeutic standpoint as well. And this is important to consider in terms of what we do in endovascular therapy. So in terms of new platforms, one could argue angiography existed for many years and decades before CT and MRI was advanced. Serial angiography at the time of baseline diagnosis and sequential imaging after every pass or every therapeutic intervention tells us a lot about what's happened. And this is the ultimate in terms of theranostics of acute ischemic stroke, where we integrate diagnostic and therapeutics together, and we tailor treatment to a specific patient with real-time information about how the pathophysiology is changing in front of us. So are we back to where we started from? Are we back to where we were with angiography before the advent of CT and MRI? I like to show this slide because it shows half a century of what has been achieved. This is actually a paper by my father when he was doing angiography at the very start of the Stroke Journal. And I'm proud to announce the new Stroke Journal that will be issued in 2021, Stroke, Vascular, and Interventional Neurology, where once again, the focus is on angiography and what we can do from a therapeutic standpoint. But the question I raised at the beginning, I'd like to raise again, which is, can we bypass the CT scanner? This is being done now. It has been done in Europe in several different settings with flat panel detector CTA. But is flat panel sufficient for a non-contrast CT scan to rule out hemorrhage before proceeding in the angio suite to your therapeutic intervention? Is it possible to go straight to angio, not have any information based on tissue, just being able to rule out hemorrhage? We'll see in coming years because there are trials, including the We Trust study that is just starting, as well as others that are direct to angio trials, where we will get the answer as to whether skipping imaging altogether, so to speak, until you get to the angiography suite is worthwhile. Once we're in the midst of angiography, in the midst of endovascular therapy, we never stop to then re-image with CT or MRI. That's extremely unusual. And typically when we do that, we stop the procedure and don't go back. But We can look at perfusion with angiography. We can look at this with perfusion angiography techniques that we've developed. But I would argue it's not the amount of blood flow on a specific parameter map that is most important. It's simply how things have changed sequentially over time, from that baseline angio to the next step with each pass, as I mentioned. This is what I think the future will hold. As I mentioned, viewing angiography of each case to me is like watching a movie. I don't know whether I'm watching a comedy or a horror movie. Sometimes it ends very well with a beautiful ending, and other times all kinds of things take place in between. A lot of drama, so to speak. And each case is a little different in terms of what the techniques are, what the result is, and I do think that this can be tailored based on your baseline collateral status. Poor collateral status at baseline may tell you that you don't want a very prompt reperfusion and extensive reperfusion, because what you may be reperfusing into may be somewhat dead tissue, and the outcome clinically may be futile to go any further. It's not that you are going to result in a futile outcome overall. It's the simple fact that that incremental step of going further may not be worth it. So we don't know necessarily when to stop or when to go further. And I think we're going to be using angiography in the future. So should we trial it? As I mentioned, we are. The use of angiography alone. So this is far beyond selection for endovascular therapy. This is selection during endovascular therapy for further steps. Direct angio is being studied, as I mentioned, and it's going to be important to look at this in terms of what we have in a lot of places, because if you only have an angio suite and you don't have advanced imaging, perhaps that's sufficient and the most reasonable thing to do. So I'm going to conclude by noting that imaging selection for thrombectomy per se is an outdated concept. This is not about selecting the ideal candidates. We're beyond that. We need to know who not to treat, and perhaps it's very few people that we shouldn't go forward with. The one-stop shop, as Professor Sikogios has coined this, is a real proposition, a real entity in the world of stroke. It is feasible to bypass a CT scanner in some cases. The question is whether we can do this routinely. Intraprocedural imaging in thrombectomy during endovascular therapy trumps the no-go decisions. I think this is going to be very important. And imaging in the angio suite is the future. Thank you, and I hope I've left time for questions as well.
Thank you very much for the both speakers for your very nice lectures. Really enjoyed them a lot. We now have time for question and answers. For in the audience, those who have questions, please key them into the system. I'll look at your questions and I'll read them out to the speakers. Please key them in as soon as you can, and we have 10 minutes to answer questions from the two speakers. While waiting, maybe I'll start with the first question to Professor Ra. Professor Ra, could you give a very nice talk just now with a patient who had 30 hours before the patient was treated? That's a very long window. So the question was late. How late is late can we go? Can you advise us on what you think would be the maximum time after we should say don't bother? Because patients may come late and expect to be treated at what time they come. So some guidance from you, please, Professor Ra?
Yeah, actually there is no guideline for the after 24 hours yet, but as I mentioned, the recent Korean study, they made a registry for the very late time window and thrombectomy cases, and one of the longest interval was 10 days, 240 hours. Even at that time window, they felt that there is still very small core and large perfusion defect. They performed a thrombectomy. So maybe it depends on case by case. And as I told on the last slides, we cannot we cannot precisely determine at one point that this tissue is viable or not completely. So there is still many things we have to investigate. But anyway, at present, even though after 24 hours and a couple of days, if there is a large target mismatch pattern is still exist, then I think we can try the thrombectomy, but it's out of the guideline at present, I think. Yeah.
Thank you. Professor Libeskind, you have some comment on that question?
Yeah, I mean, I think that the time is hard to define in those cases. What does it mean at 12 hours versus 16 hours versus 24 versus 36? The main message is that there's no real meaning behind it in terms of the time on the clock. It's really the imaging time per se.
Thank you. Because a question has just come in about futile recanalizations. When should we not bother to do it? When some patients say, well, based on this criteria, we should not. Because right now the guidelines have tell those up to 24 hours using advanced imaging. But when is it futile? Maybe Professor Libeskind could start first, and Professor Ra could tell us about futile recanalizations.
There's some individuals that will claim that there is no such thing as futile recanalization. And you'll hear this, I think, more and more in the next year. That first of all, as I mentioned, before you say that you're not going to treat that patient, it's not necessarily because that patient's going to have a bad outcome. As a great example, we know very well, I was saying this earlier today, that the endovascular therapy for COVID positive patients, where we have multiple organ systems involved, has been a nightmare. Patients with COVID that we take to the angiography suite, in general, we know that they're very sick. They're not going to have a good outcome. The likelihood of a modified Rankin score of 0 to 2 at day 90 is low. That doesn't mean that it's futile. Futile has to be individually defined. Is it futile for that one patient? And this is particularly difficult in COVID because there are a lot of younger patients who then may have very good recoveries after this subacute phase. So it's an open question. I think the question will really be answered by, if we get the low aspects or large core trials that tell us that with a very large lesion size that can be specifically defined, that there's no chance of improving those patients. Then that would be the sole definition of futile recanalization.
Thank you. Professor Ra, would you like some comment on this futile recanalization question?
I'd like to answer another question for the direct MT result. So
sure.
The point of the question is when you see a patient with both IVTPA time window but also we can identify the large vessel occlusion, then should we start IVTPA first or endovascular thrombectomy first? Yes, sir. Actually, the direct MT result is declined to the endovascular thrombectomy, and there are many parallel studies are going on. So at present, the guideline does not determine which one should go first, but I think maybe. Yeah, it is very likely that if we can start a thrombectomy within 4.5 hours, then I think we should go first for the endovascular thrombectomy and bypass the IVTPA in case like that. If there is strong evidence that large vessel is occluded. But I think, it is not guideline based.
Yes. Thank you. A comment was raised by one of the audience that penumbral imaging will help define the malignant MCA profile, and going to the angio directly might miss this situation. Libeskind, what do you think about that imaging helping to tell us which patients maybe would be more harmed rather than helped?
I'm not so sure of that. Penumbral imaging. So first of all, advanced imaging will help define a malignant profile. But the argument about whether it's the penumbral pattern where the collaterals are very poor are going to define a malignant profile. Even the diffuse trialists admitted that the malignant profile actually can be misleading in 1/3 of cases based on your advanced imaging in CT. That even those patients that are identified with a malignant profile, a subset of those do well after endovascular therapy. So I think we have to be very careful because we're using non-invasive imaging to put a label or a diagnosis of a malignant outcome when their outcome may not be malignant. And if you're wrong 1/3 of the time, that is a problem. And once again, there's a difference between imaging and angiography. Angiography, the goal is therapeutic. You have an opportunity to intervene. The imaging is only going to tell you whether to treat or not to treat, and you're